Assalamualaikum. I would like to present my FYP, which is entitled the correlation between dietary intake and serum phosphate and calcium among hemodialysis patients at Hospital University SAINS Malaysia. Continuing to the introduction of this study, chronic kidney disease is a major health problem with growing trend globally and is a major growing health issue in developed and developing countries worldwide, including Malaysia. From National Health and Mobility Survey in 2011, prevalence of CKD in West Malaysia was 9.07%. The prevalence has increased to 15.5% in 2008. When GFR less than 15 ml per minute, a person has reached end-stage kidney disease, at which point kidney function is no longer able to sustain life over the long term. Due to the decreased ability of kidney to excrete phosphorus load as glomerular filtration decreases, most patients with end-stage renal failure have a predisposition to an elevated level of serum phosphorus. When bone resorption exceeds bone formation rates in CKD, phosphorus and calcium release contribute to hyperphosphatemia and hypercalcemia. Continuing to the problem statement, a positive phosphorus valence is frequent in conventional dialysis patients, especially when they are well nourished. This contributes to the hyperphosphatemia, elevated calcium phosphate product, and soft tissue calcification, which in turn are emerging risk factors for cardiovascular morbidity and mortality. Poor compliance with dietary restriction and the conflict between adequate protein and phosphorus intake are well-known problems in clinical practice. A diet including low phosphorus content food or food with lower phosphorus content program often should be followed, and this type of diet have poor compliance from the patient. Education about hidden source of phosphate should also be given, namely about highly processed, fast and convenient food containing phosphorus as an additive. Thus, scientific data on dietary intakes and hemodialysis patients, particularly concerning phosphate and calcium, are crucial to assist healthcare providers in planning appropriate treatment for end-stage renal patient disease. So this is the research question. Is there any significant correlation between dietary intake and level of serum phosphate in hemodialysis patient at HUSM? Is there any significant correlation between dietary intake and level of serum calcium in hemodialysis patient in HUSM? What is the prevalence of hypophosphatemia? What is the prevalence of hypercalcemia? Continuing to the objective of the study, the general objective is to study any correlation between dietary intake and serum phosphate and calcium among hemodialysis patients at Hospital University SAINS Malaysia. The specific objective is to determine any significant correlation between dietary intake and level of serum phosphate in hemodialysis patients at Hospital University SAINS Malaysia. To determine any significant correlation between dietary intake and level of serum calcium in hemodialysis patients at HUSM. To determine the prevalence of hyperphosphatemia among hemodialysis patients in HUSM, and to determine the prevalence of hypercalcemia among hemodialysis patients in HUSM. So this is hypothesis 1. Continuing to hypothesis 2. And this is the significance of the study. This research is conducted to examine any significant correlation between dietary intake and serum phosphate and calcium among hemodialysis patients at University SAINS Malaysia. However, the link between dietary intakes with the manifestation of hyperphosphatemia among dialysis patients are still unclear and require more studies. Therefore, this research seeks to fill the gaps. The finding of this study will helpfully identify the correlation between dietary intake and serum phosphate and calcium, as well as finding out whether the value of the serum phosphate and calcium might show the presence of any clinical signs and symptoms such as hyperphosphatemia and hypercalcemia. The outcome of the study also able to show the prevalence of hyperphosphatemia, among hemodialysis patients in Hospital University SAINS Malaysia. So this is the conceptual framework. Continuing to the literature review, the acceptance rates for both hemodialysis and peritoneal dialysis nearly doubled, while the prevalence rate had increased by more than twofold over the last 10 years. This shows the prevalence of patients with dialysis treatment is increasing. The overall prevalence based on age was reported that the highest treatment rates remain in the 50 to 64 and more than 65 age group, but the overall trend suggests that the rates are beginning to plateau for all the age group in the last. Patients with serum phosphorus in the 6.6 to 7.8 mg per deciliter range had a 30% higher mortality risk than patients in the reference range of 4.6 to 5.5. Patients in the highest phosphorus quantile had a relative mortality risk 34% higher than patients with serum phosphorus in the reference range. The median corrected serum calcium level had remained constant for the last 10 years. 54% of HD patients achieved target serum calcium of 2.1 to 2.37 compared to only 46% of PD patients. The corrected serum calcium phosphate product had remained relatively stable in both HD and PD patients. Continuing to the methodology, the research design is a cross-sectional study, and the location of research is at hemodialysis unit of HUSM. The sampling method is non-probability purposive sampling, and the sample size is 168 based on the formula by Daniel 1699. And on the right is the how we calculate the sample size. The study population. The reference population is all patients attending HUSM. The target population, all patients undergoing hemodialysis treatment at hemodialysis unit. The source of population is all patients undergoing acute chronic hemodialysis treatment at hemodialysis unit. And the sampling frame is all patients undergoing chronic hemodialysis at HUSM. This is the inclusion and exclusion criteria. Continuing to the research tool and material, for the socio-demographic profile were obtained from the respondent medical report and dialysis record, including the age, gender, educational level, current employment status, and current estimated household income. For the anthropometry, is obtained also from the respondent medical report, and dialysis record. Weight and height will be measured using weighing scale and stadiometer only if the data is not available. For the biochemical data, also obtained from the medical report, which comprise of renal function test, liver function test, electrolyte, and serum sodium. Serum phosphate and calcium, the cutoff point of the normal value for phosphate is 0.8 to 1.6. And for calcium is 2.0 to 2.6, and the dietary intakes of patient is assessed using 24-hour diet recall. Respondents were required to recall and record all food and beverage consumed. Food album and set of household measurement were used to guide respondents in estimating portion size. This is the data collection method. The flow chart of the study, and continuing to the data analysis, percent correlation coefficient test was performed to identify the correlation coefficient. Analysis between phosphate and calcium serum and dietary intake. Descriptive statistics including means, range, standard deviation, and frequency were used to present the respondent demography, clinical characteristic, energy, and nutrient intake. Anthropometry data and biochemical data were compared with the recommended value from the medical nutrition therapy for chronic kidney disease. Numerical data will be presented as mean or median based on their normality distribution. Meanwhile, categorical data will be presented as frequency, which is the percentage. For macronutrient analysis, the consumed food and drink were converted into gram before nutrient analysis using USDA food database and Malaysian food composition table and as the food databases. Adequacy of the nutrient intake, which is the total energy, protein, fluid, sodium, potassium, phosphorus, and calcium, were compared with recommendation value in medical nutrition therapy for chronic kidney diseases. This is the expected outcome, the Gantt chart, and this is the ethical consideration. Continuing to the result, based on the table, we can see that most of hemodialysis patients had undergone treatment in hemodialysis unit of HUSM were male, which 23 out of 38 patients were from male and the remaining 15 are from female respondent. Also, based on the table, the mean of age was 51, and we can see that out of 38 patients, 27 of them were below 59 years old and 11 of them were aged 60 and above. The rest of the respondents participate in the study were all coming from Malay races. 34 of the respondents, which is most of the respondents, were married, and only 4 of the patients were not married. The academic status of patients, which majority of them have certificate of SPM, which is total of 16. 3 of them with academic status of UPSR, 1 of them were PMR. Respondents with degree academic status were 2 of them, and respondents with master also 2 of them. 4 of them with other type of academic status. The mean of individual income are 1.79, which majority of the individual income are below than 1,000, which is about 24 of the respondent. The mean of household income are 2.42, which also majority of them. 4 of them are income at below than 1,000. Hypertension are the highest leading of comorbidities among respondents, aside from the chronic kidney are the highest. 22 of them were diagnosed with diabetes mellitus, which also become the second comorbidities aside from chronic kidney disease. Continuing to the anthropometric data, in this study, the mean of the dry weight of hemodialysis patient was 59.78 kg, with the standard mean height was 157.17 cm. The mean body mass index of the respondent was 23.68 kg per meter, with the lowest BMI was 17.14 and the highest BMI was 31.80 kg per meter. Based on the table, we can see that most of the respondents in the study were on a normal BMI, which 24 of them are normal BMI. Only 1 of the respondents was in the underweight BMI range, and 13 of the respondents were on the overweight range of BMI. The mean of the interdialytic weight gain of the respondent was 2.11. Interdialytic weight gain of patient is obtained in the medical record folder, which is recorded by the nurses. Interdialytic weight gain is the weight difference between post-dialysis and pre-dialysis weight. For the biochemical data, this is the serum phosphate level. Based on the table, we can see that in the study, the mean of serum phosphate level among hemodialysis patients is 3.0 millimole, with the lowest serum phosphate level is 1.04 millimole per liter, and the highest serum phosphate level was 2.97 millimole per liter. We can see that most of the serum level of the respondent in the study were high, which was 30 of them are high on the serum phosphate level, which also indicate that most of them are hyperphosphatemia. Hyperphosphatemia is defined as an abnormally high serum phosphate concentration of more than 1.46 millimole per liter It is principally observed in patients with reduced kidney function. None of the respondents have low serum phosphate level, and 8 of them has normal level of serum phosphate level. Serum phosphate level of patient is obtained in the medical record folder, which was the result based on the latest blood test result. For the serum calcium level, the table shows that in this study, the mean of the serum calcium level among hemodialysis patients was 2.31 millimole per liter, with the lowest serum phosphate level is 2.13 millimole per liter, and the highest serum calcium level was 3.19 millimole per liter. Based on the table, we able to conclude that majority of the respondents have their serum calcium level were normal, which was 26 of them are normal on the serum phosphate level. None of the respondents have low serum calcium level, and about 12 of them has high level of serum calcium level, which also indicate that 12 of them are hypercalcemia. Hypercalcemia is defined as serum calcium concentration 2 standard deviation above the mean value. The normal serum calcium ranges from 8.8 mg per deciliter to 10.8 mg deciliter. The serum calcium level also obtained from the medical record. Continuing to the dietary intake, this is the dietary calcium intake. The table shows that the mean of total energy intake was 1386, and the lowest intake of the respondent was 6012.83, and 3038 kcal was the highest intake. Based on the table, majority of the respondent, which was 37 of the respondent, were unable to achieve the recommended intake. They were in the low intake of calcium, which is less than 1000 mg per day. Only one of the respondents are able to achieve the recommended nutrient intake for daily calcium intake. There were no respondents that will exceed the tolerable upper intake of daily calcium intake, which is more than 2000 mg per day. The guideline of the daily calcium intake was referred from the recommended nutrient intake of Malaysia, RNI 2017. Although none of the respondents had exceeded the daily recommended calcium intake, 12 of the respondents' serum calcium level indicate that they were hypercalcemia. And for dietary phosphorus intake, based on the table, half of the respondents, which was 19 of the respondents, were unable to achieve the recommended intake, and they were in the low intake of phosphorus, which is less than 700 mg per day. The other half of the respondents, which is 19 of the respondents, are able to achieve the recommended nutrient intake for daily phosphorus intake. There were no respondents that will exceed the tolerable upper intake of daily phosphorus intake, which is more than 4000 mg per day. The guideline of the daily phosphorus intake was also referred from the RNI 2017, and although none of the respondents had exceeded the daily recommended phosphorus intake, 30 of them are high on the serum phosphate level and indicate that they were hyperphosphatemia. And continuing to the correlation between dietary intake and level of serum phosphate in hemodialysis patient at HUSM, and based on the analysis given, it was concluded that there is no significant weak positive linear relationship between dietary intake and level of serum phosphate in hemodialysis patient at University SAINS Malaysia, and this test was conducted using Spearman correlation test. And for the correlation between dietary intake and level of serum calcium in hemodialysis patient at HUSM, and also based on the analysis, it was concluded that there is no significant weak positive linear relationship between dietary intake and level of calcium in hemodialysis patient at Hospital University SAINS Malaysia, and this test also using Spearman correlation test. And for the correlation between dietary calcium intake and level of serum calcium, it also conclude that there is no significant weak negative linear relationship between dietary calcium intake and level of serum calcium in hemodialysis patient at University SAINS Malaysia. And lastly, for the correlation between dietary phosphate intake and level of serum phosphate in hemolysis patient at HUSM, also conclude that there is no significant weak positive linear relationship between dietary phosphorus intake and level of serum phosphate in hemolysis patient at HUSM. And continuing to the discussion part, the prevalence of hypophosphatemia among chronic kidney disease based on the study was conducted in April 2017 of Central Pahang Cluster Hospital. The study observed that hypophosphatemia patients tend to be younger and the median age was 46 years compared to those with normal phosphate level. Also, they also tend to start the maintenance hemodialysis early in the median age of 38 compared to the median 50.8. In this study, the occurrence of hypophosphatemia among age group was not identified and was not analyzed. Comparison cannot be made to observe the occurrence of hypophosphatemia among age group. The study also stated that as many as 40% of the patients had normal phosphate range, which was very similar to 36% among patients in the UK. In this study, patients with normal phosphate range was only about 21.1% of the total participants, which was different from the previous study. This might due to the very small sample size from the study, which only 38 samples, which the calculated sample size should be 188 samples. This may cause the result to be inaccurate. In terms of hypophosphatemia, the study observed that figure was similar to 41% found in the other large study involving 5,262 patients. In this finding, the previous study was also different from the study, as in this study, 78% of the respondents were on hypophosphatemia range, which is very high compared to the previous study. And the discussion between the dietary phosphate and serum phosphorus. Some studies show that a diet rich in phosphorus can increase serum phosphate level, and having a dietary intake of dairy food with or without organic phosphate added, as well as food categorized as cereal and grain with organic phosphate added, had a positive significant effect on the serum phosphorus. A study from Moore and colleagues also conclude that milk and dairy product with inorganic phosphate additive significantly increase the serum phosphorus concentration by 0.07. In this study, however, from the statistical analysis using percent correlation, we can see that the result showing that there is no significant linear relationship between the dietary phosphorus intake and level of serum phosphate in the patient, although patient have compromised kidney function. Although none of the respondents had exceeded the daily recommended phosphorus intake, and 50% of them have low dietary phosphorus, we can see from the result that 30 of them are high on the serum phosphate level and indicate that they were hyperphosphatemia. The finding in the study might not be accurate due to small sample size. For the dietary calcium intake and serum calcium, Bell and colleagues show that a diet rich in phosphorus can increase phosphorus level while it can decrease serum calcium level. Giff et al. Also referred to a study from Abessian et al. That showed that a low calcium intake could reduce serum calcium level in plasma. There was also a study that concluded that dietary calcium intake increased the serum calcium level in 1 hour after consumption. However, this level was decreased after 3 hours, indicating that the importance of consumption time from the diet. Several other studies show that no correlation between serum calcium or phosphorus level with consumption of this from diet, suggesting the importance of role of homeostatic control of the element in the body. Comparing to this study, it was concluded that there is no significant weak positive linear relationship between dietary phosphorus intake and level of serum phosphate in hemolysis patient. From the result, majority of the respondents, which is 97.4%, have low calcium intake, which is below the recommendation, and 68.4% of the respondents are at normal level of serum calcium level. Only 31.6% of the respondents has high level of serum calcium. The finding in the study might not be accurate due to small sample size. And continuing to the conclusion, in conclusion, the result from this study show that both calcium and phosphate intake have no significant linear relationship between serum calcium and serum phosphate. This result might not be perfectly accurate as this study does not meet the requirement sample size that has been calculated to create research that able to detect clinically relevant differences. Although the study could not find the correlation between dietary intake and serum calcium and serum phosphate, effort must be made to ensure that the patient can able to understand that their diet intake can affect their blood result and also might affect their function of kidneys. Education program or consultation announcement should be organized to help the patient understand better and to highlight the importance of healthy eating and lifestyle. This is the references, the appendices, questionnaire, the research information, and thank you.